So our next presenter is Cheryl Doncaster, who's a Senior Project Manager in the Utilization Group within Medical Services and Innovation. She's located in Halifax, and today she will be describing and providing an overview of the BloodBrief initiative and its impact.
Thank you to the organizers who need to come present today. So at the end of the session, you should be able to describe and provide an overview of the BloodBrief initiative and its impact. So a few years ago, when we were first delving into more initiatives with respect to the utilization of blood components, we wanted to come up with kind of a keystone initiative with respect to being able to promote the optimal utilization of blood components and products. And we wanted to do this really by heightening the hospital awareness of their issue trends, so the amount of blood components and products that are issued to their hospital sites over a certain amount of time, and we wanted to tell the hospitals how they compared to other hospitals. So we put our thinking caps on, and we ended up coming up with the BloodBrief initiative. It was introduced in September of 2013. The first topic we tackled was O-negative red blood cells, because the use of O-negative blood cells, the percentage and the proportion, was increasing at that point. So what we did is we decided to target the top 50 hospital users of O-negative red blood cells. And we wanted to go beyond traditional communications that we've had with hospital blood banks. And so we engaged transfusion committee chairs for the top 50 hospital users. The first BloodBrief, it wasn't really brief at all. It was 9 pages long. But it did contain 3 years of issued data for the O-negative red cells. All of the hospital comparator data was anonymized. And there was rankings there. So hospitals could see where they ranked within the top 50, and then also within respective peer groups in terms of whether or not they were predominantly a pediatric site, whether they were a tertiary hospital, or a community hospital. So since that time, it was widely received and generally quite positive from the hospital community. So since then, we've expanded the BloodBrief, and we've made it briefer, although it includes issue data for all hospitals now that receive the targeted blood component or plasma protein product within the last fiscal year. So we still include 3 years of issue data. We're starting to incorporate cost data and also the disposition data that hospitals share with us on a monthly basis. Previously, it had been communicated and sent to hospitals via email. The BloodBrief is now available online on blood.ca. We do still send a direct notice to the hospital transfusion committee chairs telling them the most recent BloodBrief has been posted online. The ranking is still there, so we still rank the hospitals within the total number of hospitals that receive the particular component or blood product. We've tried to improve the hospital peer groups for comparison. So it's somewhat better than it was, and so we're adding new information, such as whether or not the hospital was a trauma, depending on the blood product, of course, and whether or not they were a trauma site. And now there is still some hospital information there that is anonymized. However, we asked hospitals if they would be willing to have themselves identified within the data set. This had been a request from a previous survey we had done, and a suggestion from a hospital physician to say, why don't we just identify ourselves? And so we've started to do that. And as of today, 65% of our hospital customers have agreed to be identified within the BloodBrief, which is fantastic. So in terms of the topics that we've tackled or so far, we've done O-negative red cells, and this BloodBrief is released every year in the spring. generally in April or May, as soon as the most recent fiscal year is finished, and it gives the hospitals time to send in some of the disposition information. So then we'll release that blood brief. AB plasma is a blood brief that we release in the fall. We've tackled IVIG. That seems to be released in around the fall period as well, although we've moved, the initial release was in the fall, and we've since moved it to the spring, so that it follows the O-negative red blood cell blood brief. We did do a single release for CMV seronegative platelets, and the most recent topic that we've introduced a few months ago tackled the cryoprecipitate and fibrinogen concentrate products. And so the next blood brief will be released, and we'll go back to the O-negative red blood cell blood briefs, and we'll tackle that one in the spring again. We're certainly really open to any suggestions for topics for the blood brief, and that's generally where we get the ideas for our next topic. So essentially the blood brief, we provide, Dr. Catherine Weber provides an overview of the topic. And it's essentially a 1 to 2 page note that talks about the current state in terms of clinical practice. She makes reference to some of the recommendations and guidelines around a particular product. And so that introduces the topic to the intended stakeholders. And then we release the data sets that are provided online and they're in PDF format and are generally grouped. So the first 100 hospitals are within one document, and then they're subsequently grouped. Or if there's a special peer group of hospitals that fits together nicely and is called out, then that's issued as a separate document. But everything is online for easy access. So we wanted to see, when we initially released the blood brief, we had done a survey, and we wanted to see how well the blood brief concept was being accepted, and it was. We had positive feedback. So where we had gone beyond the top 50 hospitals, we wanted to survey all the hospitals, most of the hospitals, again, to see really, are we having the same impact? Because the product is quite labor intensive to get out in terms of the blood brief itself. So we wanted to make sure that we were focusing on our efforts in an efficient way. So between February 12th and March 9th, 2016, we selected 100 hospitals that would participate in our survey. It involved surveying 77 transfusion medicine committee contacts that represented the 100 hospitals. 89 of the 100 hospitals had been identified as a top 50 hospital on at least one of the last 4 blood briefs that had been released since July 2015. The other 11 were chosen randomly outside of the top 50 list. So the respondents, the way we did the calculation, we ended up with the respondents that responded to the survey ended up representing greater than the 100 hospitals. A total of 25 started the survey, 19 completed it, 6 were from a single hospital, but 13 respondents represented a group of hospitals, some of which were quite large. 85% of the respondents were not aware how their hospital, before receiving the blood brief, were not aware of how their hospital ranked with other hospitals. 90% told us that the blood brief highlighted data and information that wasn't new. So that either included they weren't aware of their ranking, they weren't aware of that they were a top user, or what the 3-year issue trends were, or even the cost of the product that was being issued to their site. 85% of respondents reviewed transfusion practice or blood component product demand as a result of looking at the blood brief and seeing where their hospital was ranked and all the data that accompanied that. All of the blood brief topics prompted transfusion policy review or change. So it means we were selecting topics that were meaningful to the hospitals. 29% of the respondents said that the topic of the O-negative red cells prompted transfusion policy review or change. 21% said AB plasma, 18% said CMV seronegative platelet blood brief triggered an action, and 11% indicated the IVIG blood brief. So for those hospitals that actually made changes to their transfusion processes and policies, or at least reviewed their policy, they indicated that they made changes for the requirements for CMV seronegative platelets. They looked at stocking other plasma groups to reduce the AB plasma use. If they didn't have them, they were tweaking recommendations or creating recommendations guiding the use of IVIG. And they were making changes with respect to the policies around providing ONEG in uncross-matched situations and limiting that to women of childbearing age. There were hospitals, of course, that opted not to review their transfusion practice or policy as a result of BloodBrief, and they cited using an already very strict transfusion policy, so they felt they couldn't improve any more than what they already had. So in conclusion, we felt that the results of our 2016 effectiveness survey really confirmed the findings from 2014. The BloodBrief continues to be effective in promoting optimal utilization of blood components and products, and that heightened awareness of issue trends over time and comparisons within hospital peer groups influences hospital transfusion practice and policy. So thank you very much for listening, and I'd also like to thank, obviously, our hospital customers and those within Canadian Blood Services that certainly assist with this particular tool that we've developed. Dr. Catherine Weavert as our leader, and the account management team. Although we do send the notices out saying that the BloodBriefs are available online, it's really the account management team and the hospital liaison specialists that make sure the dialogue around particular blood products or components happen all year long. So thank you very much.
Perfect. Thank you very much, Cheryl. That was a great talk. So, is there anyone in the Alberta room that has a question for Cheryl? So you mentioned that 65% of the hospitals are identified in these BloodBriefs. Do you think there's any differences in whether or not they've changed their utilization practices between the groups that are identified versus those that choose to remain anonymized?
That's a really great question. We haven't delved in it to that extent. We do know, though, that there are hospitals that have fantastic practices already, and their numbers are probably some of the best that you can see on the BloodBrief in terms of utilization, and they've chosen not to be identified. So I don't know if it's directly related or not.
So this is a question from Karen Jowsey, who wants to know, do the transfusion teams effectively communicate to those ordering and issuing blood products?
It's certainly a best practice that's promoted. I think in all situations, communications can always be improved, even within Canadian Blood Services. So that may be the case where there may be some gaps in communications, but certainly there are some really great efforts going on in the field with respect to encouraging and doing more communication with respect to the best practices that are being used in other hospitals. And hospitals are really asking us and asking for and communicating with amongst each other about, well, why are you doing so much better? What's different in your site? And so they're certainly communicating amongst each other.
Thank you very much, Cheryl, for presenting. That was great.